Ma'am, we are live.
Yes. Okay. Welcome everyone. I am Dr. Shailaja Kale from Pune, and today is this event of diabetes dilemma, and we are going to discuss and talk a lot. You have questions about brainstorming the burning issues. In today's topic, we will be discussing about in-hospital hyperglycemia. And as you know that we have this series of interesting scientific event, and you can go on the web page and see www.diabetesdilemma.com, where you can see all the previous sessions which we have uploaded. Once you have a code for registration at our Diabetes Dilemma page, you can see all the recorded events, which are, I think, about 17 to 18 events in last, I think, 4 months, which you can visit and listen to. I'm happy to say that today we are going to have a in-hospital hyperglycemia, and Dr. Sanjay Agarwal and Dr. Yogesh Asava. We are sorry to say that Dr. Yogesh Asava could not join. As you know, his introduction was physician and intensivist, which shows that he is quite busy today and he couldn't join. I'm very proud to introduce my friend, Dr. Sanjay Agarwal, today's respected faculty. Dr. Sanjay Agarwal is physician diabetologist. He's MD fellow of American College of Endocrinology, and he's heading the Department of Medicine at Ruby Hall, Pune. He's a consultant at Jahangir Hospital. Most important, he has brought Secretariat, the Office of RSSDI, National RSSDI, to Pune. So thank you, Sanjay, for bringing that office to our own city, Pune. He is also Honorary Secretary, Governing Council, National RSSDI member, and also Maharashtra State Chapter Council member. He is organizing chairman for IDEC Pune, that we all know. He is member editorial board BMJ Open Diabetes Research Care Journal. So I welcome Dr. Sanjay Agarwal for today's meeting. So in today's topic, it will be in-hospital hyperglycemia, which is now more pronounced as we have lots of COVID patients, which we have seen in last few months, last one whole year. And I think glucose is the one thing, very important aspect of the whole management. So the in-hospital ICU hyperglycemia management is actually, each one is struggling. So it's very important topic for everyone, whoever joined today, that's what I feel. Just 2-3 slides to introduce today's topic. As you can see in this slide, that there is a glucose fluctuations. Both person has the same A1C of 7%. But you can see in one person's glucose in continuous glucose monitoring is fluctuating a lot, and other person's glucose are not fluctuating. Same thing you can see here. This is one person with A1C of 7.8. But you can see the nice graph on continuous glucose monitoring, while the patient B, same A1C, but the glucoses are varying a lot. And such kind of variation are very commonly seen when the patients are admitted, not because of inbuilt variability, but when the patients are admitted, these peaks and the valleys happen because of the treatment also, because of the choices of insulin, because of the doses and injection. It happens that these things have more kind of a pronounced when patients are admitted. So you can see here that this is time in range, and you must be seeing this slide again and again. So this person's all glucoses are above. So he's 0% time in range. Otherwise, this individual is 100% time in range. His glucose are fluctuating between 70 and 180. Most of the time, we want our patients to be 70% of the time, their glucose should fall in time in range. In hospitals, we want it 100%, but it is not possible every time. So it may happen that there are big fluctuations. Why this is important? Because the mortality of the patients or the outcome of the indoor patients, actually this is a paper which actually says about glycemic variability and the mortality. You can see here that this is high glycemic variability is associated with increased mortality, more so in patients who are not known diabetes earlier. So patients who were non-diabetic got diagnosed as a hyperglycemic on first time on admission. They show the worst outcome with more variability. Even though they are first time having glucose and they have a low glucose variability, you can see here the mortality is much higher in the patients with lot of fluctuations. Then come, of course, high glycemic variability and diabetes. This was about 1200 odd patients in ICU who were put on continuous glucose monitoring, and it was just published in the month of May. You can just read. So this was the critically ill patient study, and there are lots of studies which have shown that kind of a similar picture or similar outcome, which shows that more is the glucose at the entry or at the time of the admission of the hospital, more the fluctuations, there are more kind of a worst outcome. So this becomes the principle of managing the in-hospital hyperglycemia, where we don't want severe hypoglycemias and we don't want peaks. And this variability also is increased because of our treatment many times using different regimens. So let's address all these issues today in this discussion. Let me first thank today's sponsor, say Novo Nordisk, for sponsoring this today's diabetes dilemma scientific talk, which we are talking of in-hospital hyperglycemia. Novo Nordisk, thank you so much, as well as all other sponsors of Diabetes Dilemma series who are there as academic partners for Diabetes Dilemma. So thank you so much, everyone. And let's invite Dr. Sanjay Agarwal again for today's his lecture. So Dr. Sanjay, over to you. And then we will have, after his lecture, some question answers.
Sure. Thank you so much, Dr. Shailaja. Thank you for your kind introduction. It's a pleasure to be at your meeting and have such a wonderful academic discussion. I think you set the tone of my lecture very well, outlining the importance of control of glucose in the hospital environment, something that is very little talked about, and one of the most important things to practice if we have to improve outcomes of our patients when they are hospitalized. I'm just going to share my screen and take it.
Yes.
I hope my screen is visible to you.
Yes, we can see it.
Thank you so much. All right. So as I just mentioned that Dr. Shailaja just set the tone of the lecture, and this lecture has actually become more relevant today, given the scenario of the pandemic, where we are seeing more and more patients who are coming into the hospital. And we know that patients who have diabetes as a comorbid situation tend to do worse off than patients who are not having diabetes. And obviously, when the patients come into the hospital and their blood sugars are not at goal, it becomes highly important that we should try and get them to goal as quickly as possible to improve outcomes. Now, there could be another situation where, because of the stress of infection, they may actually become hyperglycemic for the first time. And that would also be another possibility where we would be handling the situation to control their blood glucoses. So why are we so concerned about raised blood glucoses in the hospital? And is there really definite data which shows that if we improve the blood glucose, does it change outcomes? And let me go back to history, where we can see this trial by Tony Finario. He was a cardiac surgeon, and he looked at all his patients who were not doing well. And one of the most important factor that he found, which was related to adverse outcome, was presence of hyperglycemia. And he showed that as the blood glucose increases, let me try and get my pointer in. Okay, so as the blood glucose tends to increase, so does the post-operative mortality tends to increase with the rising blood glucose values. If you can bring the post-op blood glucose down, you obviously reduce the the outcome significantly. And here you can see in this equation over here, if your blood glucose is less than 200, in the first post-op day, the mortality is 1.8%. But similarly, if the blood glucose within the first post-op day is more than 200, the mortality increases to 5%. So clearly you can see that there is a rise in the mortality if immediately your blood glucoses are not at goal. So what are the variables that really affect outcome? So it's the first post-op glucose, that's important. And if you find that the patient has got hyperglycemia, which is not at goal, it increases the length of stay by 2 times, increases the length of the duration of ventilation by about 3 times, and mortality increases by 7 times. So clearly, there is a strong case that we should try and get the patients to better glycemic goals as quickly as possible if we have to improve outcomes of our patients once they're admitted. This was a very landmark study of the Vandenberg trial or the Lucine trial. And here you can see that in this study, they sort of randomized patients into two groups. That was the conventional and the intensive. In the conventional, the target blood glucose kept was between 180 and 200. And the insulin was started once the blood glucose was more than 210. In the intensive, the target was kept between 80 to 110. And anything more than that, the patient was started on insulin therapy. This was a trial which had enrolled about 1,500 and odd patients, and they were primarily from the surgical ICU, with a subset of patients who were from the post-cardiac surgical unit too. What they did show was that patients who had an intensive control had significantly improved outcomes when the mortality reduced, the bacteremia reduced, the length of requirement of antibiotics or ventilation reduced, the need for dialysis reduced, and the hospital stay was also reduced once you improved the blood glucose targets to intensive group between 80 to 110. After this trial, there was a whole interest in this area that developed, and there were a number of papers that came forth which showed that there was definite benefit in terms of intensive control. But what we did realize is as we try and improve control, so does the mortality increase, and this mortality was primarily because of hypoglycemia that the patient tended to get with very strict control. Now, another factor that we always have to keep in mind is why does really hyperglycemia result in poor hospital outcome? We know that it triggers off a metabolic stress response. The stress hormones increase, the peptides increase, there is a hyperglycemia, and there is a relative insulopenia. All this leads to immune dysfunction, increase in ROS transcription factors and secondary mediators. There's an increase in free fatty acids, increase in ketones and lactates. There is an infection dissemination that tends to occur. And ultimately, in a common pathway, there is a cellular injury, apoptosis, inflammation, tissue damage, altered tissue and wound repair. And all this tends to cause a prolonged hospital stay, disability, and death. Now, this was the earlier studies that came after the Vandenberg trial, where Tony Finario showed that in an ICU setting, patients who underwent cardiac surgery, improving the glycemic control reduced the infection by almost 65%. They also showed that mortality reduced by 57%. Crinsley looked at both medical and surgical ICU patients, and they showed that there was a mortality reduction by 29%. But what they they were not able to demonstrate was the significant benefit that was seen in the surgical ICU patients. The same was not extrapolated in the medical ICU subsets of patients. And then Vandenberg went back and looked at medical ICU patients, and they could not demonstrate the same benefit in terms of improvement in outcomes with strict control. But what they did show was that the mortality tended to increase when you tended to put them in the intensive group with a target blood glucose of 80 to 110. Given this, they then looked at a large study, the NICE sugar study, and this was enrolled almost about 6,000 odd patients. And they showed that there was really no significant benefit when you went that low to 80 to 110. And ultimately, the good sense prevailed. And after a lot of studies, they've shown now that the target blood glucose in critical care unit should be maintained between 140 to 180. And here you can see again that in the intensive arms versus the control arms, the hypoglycemia rate was almost 6 times as higher when you try to get down to intensive group target blood glucose of 80 to 110. So now we are quite more or less accepted norm that our target blood glucose in critical care unit should be between 140 to 180, which improves outcomes. Now, whenever a patient is admitted into the hospital, he can be in three different scenarios. One is he could be an existing diabetic who comes to the hospital and has come in for treatment. He may be at goal, he may not be at goal, and we obviously need to look at his blood glucose and then titrate his treatment accordingly. The other scenario is that the patient may be previously undiagnosed. So he may not be aware about the fact that he's a diabetic. And when he comes into the hospital, in his initial evaluation, we find out that this patient is a diabetic. So what is the criteria for diagnosis is the fasting glucose should be more than 126, random sugar should be more than 200, and A1C value should be more than 6.5. There's a third category, and that is the stress hyperglycemia, where the patient at admission is normoglycemic. During hospitalization, the patient tends to show typical hyperglycemic values, and after discharge, the patient tends to become normoglycemic again. So the stress of illness, the sympathadrenal response, the stress hormone response can cause the hyperglycemia to happen. And once the entire background event improves, the patient tends to become normoglycemic. It is highly important that we should do an admission A1C of our patients, which differentiates our patients from an undiagnosed diabetes versus a stress hyperglycemic response. So an A1C value would be tend to be high when patients who are not been diagnosed and has come into the hospital and detected for the first time, versus somebody who develops stress hyperglycemia, where we expect that the A1C values will be tended to be normal. And this was something which Dr. Shaila just alluded to a short while back when she showed that the glycemic variability in patients who are newly diagnosed tended to have a worse outcomes than patients who are established diabetes under good control, and they tended to do better than patients who are newly diagnosed. So this was a study by Dr. Guillermo, and he looked at all patients who came into the hospital, and they selected about 2,000 odd patients in the group. They defined hypoglycemia as fasting glucose of more than 126 or random glucose of more than or equal to 200. And they showed that about 62% of the patients tended to be normoglycemic, about 26% were known diabetic, but 12% were patients who had a new onset of hypoglycemia. Only thing they did not define the A1C in this group, so it was difficult to find out whether these were new onset hypoglycemia or undiagnosed hypoglycemia. And this was something as an extrapolation to what Dr. Shaila just showed, that if you look at patients who are normoglycemic and patients who had a history of diabetes, the mortality, of course, tends to be higher in patients with diabetes, but patients who are newly detected diabetes tends to have a much higher mortality when they are not adequately controlled. And that is something that has also been shown by various other studies. Also equally important is the fact that if you fail to identify diabetes during the first admission, the rehospitalization rate is almost about 3.5 times more where the patient comes back to the hospital for some other reason. So it's important that we should never miss out diabetes during the hospitalization, because readmission rates for all these patients tends to be higher if you're not controlling their blood glucoses adequately. This was a paper, the guidelines that we wrote in 2016 from the RSSDI, where we came out the clinical practice recommendations for management of in-hospital. And I would urge all of you to read this document, where we have elaborated how the entire control, diagnosis, control, monitoring, all should be done in various case scenarios. And this is a very well written out document, which I would urge all of you to read. I'm going to talk a little bit about excerpts from this document. So whenever we are managing patients in the hospital, when the patients are in the critical care units, more or less, more of us would tend to decide to give the patient an intravenous insulin drip. Once they're better and they've settled down and we're transitioning them to the wards, we tend to give them subcutaneous insulin. Often we give them a basal bolus regime. And then once the patient is recovered from his primary illness and we have to discharge the patient, the choice would be either to continue on basal bolus, or at times we transition them onto premix insulin for better compliance. Or if the requirements are not very high, we could possibly put them on to pre-admission treatments, as we will talk about it in a short while. I'm going to illustrate a case to you. This is a Mr. CSA, 45 years old, diabetic for 6 years, admitted to the ICU with left leg necrotizing fasciitis with septicemia, has been fairly well controlled on oral agents. His labs showed that WBC is 22,000, polymorphs are 86, random glucose is 456, urine ketones is positive. There's no acidosis on the ABG. Urea level is 56, creat is 1.4, LFTs are normal, and blood cultures and wound cultures were set. The question is, what should be the glycemic goals in this patient, and what would be the plan of management of his blood glucose? As I just told you some time back, this was the ACE recommendation, and this is something that we still follow in the critical care units, that less than 110 is not recommended. 110 to 140 has been shown that only patients with post-cardiac surgical patients have shown a benefit in this, to keep their blood glucose between 110 to 140 in the immediate post-cardiac surgical time. But more or less, we would keep the patients between 140 to 180 in all our patients, and more than 180 is not recommended. So, and we would tend to start insulin once the blood glucose is more than 150 to maintain the blood glucose less than 180. So this is by and large the dictum that we would follow, and it is followed even today. Now, this was the recommendation that we gave in our document from the RSSDI. So how do you really calculate the dose of insulin that we would give in an insulin naive patient? So you would decide that how much insulin. So suppose the blood glucose of the patient is about 400. You divide the blood glucose by 100, and that should be roughly an infusion rate that you would start the patient on. You would give a priming bolus of 0.1 units per kilogram per body weight. Now, there is obviously a titration of dose that needs to be done. And if you find that the change in blood glucose, subsequent blood glucose, is more than 30%, then you more or less continue the same infusion dose. If the change in blood glucose is less than 30 milligram percent, then you tend to increase the infusion rates. And if the blood glucose is not really changed from the baseline values, you obviously will tend to increase the infusion rates. So based on this, we've made this algorithm, which I can share with you, anybody who needs it, or you can go to the document and see it. And you can see here that based on the blood glucose values that you keep monitoring, you need to titrate the doses up or down, and you need to sort of bring the glucose under a tight control. The advantage of using an algorithm-related titration is that you are able to bring down smoothly the blood glucose and maintain it at a narrow bandwidth without much of glycemic variability, which is rather advantageous. Now, this is just one of the algorithms that we have really proposed, but there are a number of algorithms in literature that you can follow. Follow any algorithm which is easy for you to manage. Not only you, but your entire team should be able to manage easily, because some of the algorithms can be very complex, and you may find that it may be difficult to follow those algorithms. So there are a number of algorithms, and you can follow anyone that you prefer. Now, at times that the patient may go into the hypo range, and at that time you need to hold your insulin. And if the patient actually goes hypoglycemic, then you need to give dextrose to the patient to improve his glycemic status. And the way we calculate that is you decide that 100 minus blood glucose into 0.8, and that is the amount of dextrose infusion that you need to give the patient. If the blood glucose is less than 70, you check blood glucose every 15 minutes. If it is more than 70, check every 30 minutes till the blood glucose is more than 90 milligram percent. If it is more than 90, check hourly. And after the blood glucose is more than 180, you restart the infusion at 50% of the previous rate. Now, at times, you may not have insulin pumps available, and you may need to use a microsets. And this is the drip rate that we recommended for patients who would tend to use a microsets. And these are the drip rates that have been recommended by us. Please remember one thing: there is no place for something that we always practice is a dextrose insulin drip. That is something that we have given away because the amount of insulin that is delivered to the patient is very erratic, and we don't know. There could be a rapid runoff, there could be slow, or at times the insulin may stick to the plastic tubing. So how much of insulin the patient is actually getting, we may not come to know about it. So this is something that we need to generally avoid, that do not give the patient any dextrose insulin drips. Now, often we get asked the question that when we are giving intravenous insulin, that is it better to give conventional insulins or should we use analog insulins to the patient? And this was a paper that looked at this entire thing. They looked at patients who are in diabetic ketoacidosis and they were randomized to give analog versus conventional insulin. And you can see clearly over here the blood glucose improvement, the time to improvement, and the time to decay control was no different between the two groups. And please remember that for intravenous insulin, you don't need to give analog insulins. Conventional insulins are equally effective. It has the same outcome as analog insulin. But when you transition the patient from the intravenous to subcute, they looked at patients who are on regular plus NPH versus glargine plus glulisine, and they found that the hypoglycemia rates were lower with the analog insulins. So intravenous, you could use conventional insulin, but when you transition the patient to subcute, it is always preferable to use analog insulins in these patients for the fear that you may cause hypoglycemia. Now, there are certain rules that you need to follow when you're transitioning the patient from intravenous to subcute. Continue IV insulin till the patient is able to tolerate solid food intake. Continue IV insulin at least 2 hours after the first subcute insulin injection is given. And this is a common mistake that is made in the ICUs, where the nurse tends to shut off the insulin when you give them the orders. And once the lunch comes, is given the first subcute insulin. Remember that once you shut off the IV insulin, the insulin stays in the circulation for not more than 5 to 10 minutes. And after that, there is no insulin. So by the time the subcute injection has had its effect, there would be a period of time where there would be no insulin in the body, and the patient can get a glycemic surge, and that can, in a type 1 patient, cause again a diabetic ketoacidosis. So remember that you need to give the first subcute injection, wait for 2 hours, and then discontinue the IV insulin for the patient. Don't use only basal insulin when the A1C is greater than 8.5 on 2 or more oral agents. Don't switch to oral agents from IV insulin in patients with type 2 diabetes. And effective insulin therapy must contribute to both the basal and the nutritional coverage to achieve target goals. And often when the patients are in the hospital, the requirement for insulin is high, and that is obviously because of a higher insulin resistance, which is mediated through all the stress hormones that is there in the body. I'm going to take another case, Mr. PA, diabetic for 10 years on insulin and OHAs, admitted to the hospital with a consolidation, not in respiratory distress. He's referred to the diabetologist for a blood glucose control. And this is a typical case scenario where most of us tends to come into the picture when we are referred. And the patient's lab values were 16,000, polymorphs of 80%, urine ketones were negative, fasting glucose of 256, post-meal glucose of 302, A1C of 8%, and the renal functions were normal. The question that we have to ask for this patient is what should be again his glycemic goals, what will be the plan of managing his blood glucose, and what will be the discharge plan when the patient is better. So here you can see that how should you really monitor the patients when he comes to the hospital, and how frequently should we doing the point of care testing. So all patients who come to the hospital should be assessed for a history of diabetes, obtain his laboratory blood glucose and A1C at admission. If the patient has no history of diabetes, blood glucose is less than 140, initiate point of care testing according to the clinical status. If there is no history of diabetes, but the blood glucose is more than 140, start point of care testing. If the blood glucose monitoring should be maintained, should be kept on for 24 to 48 hours, check A1C. And if the A1C is more than 6.5, then you would probably monitor like a regular patient who's got diabetes. And obviously, if there is a history of diabetes, then according to the clinical situation, you would do a point of care testing so that you can make your judgments about his insulin dosing. Uh, Most of the times, the schedule that we would tend to follow is before meals and at bedtimes in patients who are eating, or every 4 to 6 hours in patients who are nil per orally or receiving continuous enteral feeding. What should be the target glucose goals in patients who are not in the critical care unit? We defined that in the critical care units, it should be between 140 to 180. But once the patients are in the wards, a fasting glucose target should be less than 120. Pre-meal target should be less than 140. And post-meal or random blood glucose should be less than 180. You should avoid hypoglycemia and reassess insulin regimes if the blood glucose tends to fall less than 100. And obviously, if there is a fall of less than 70, you need to cut back on the insulin, or there could be definite reasons why there could be a mismatch between the insulin and the meal. And at times, the patient may be going into hypoglycemias, and you need to inquire as to why the patient is going low and then readjust his insulin dosing accordingly. Now, not all patients, when they are admitted into the hospital, come into the critical care units. There would be majority of the patients who are admitted into the wards for various reasons, and we may need to insulinize these patients. Now, these patients do not need an intravenous insulin most of the times. But if they are insulin naive and we need to start the patient on insulin, then we need to calculate the total daily dose based on which we need to decide on the insulin how it needs to be given. So based on the body weight, we tend to calculate the total daily dose. If the patient is at ideal body weight, you will calculate between zero point 0.4 to zero point 0.5 units. Obese people require a little higher amount, between zero point 0.5 to zero point 0.6 units per kilogram. If the patient is thin or is renal compromised, you need to give less insulin to these patients, zero point 0.3 to zero point 0.4. And this is where you start. Now you take 80% of the calculated dose, of which you give 50% as basal insulin and 50% as boluses, which is equally divided in the 3 meals. Let me give you kind of an example for this. So if you can see here at the bottom that the total calculated dose is about 30 units. 15 units are given as basal and 15 units are given as boluses, where you give 5 units before each meal. And then if the patient is not at goal, you have to give an additional correction boluses. Now, as a basal, if you're giving glargine, you can give it once a day, either in the morning or evening. If you're giving detimer, you have to give it as a split dose twice. NPH again needs to be given twice. And degludec, as of now, is not recommended in hospitalized patients. Now, if you're giving a basal dose, we need to sort of titrate as per the fasting glucose if you're giving in the evening, and you can keep going up by 2 units till you find that the fasting glucose is between 80 to 110. If you're giving a morning basal, you check as per pre-dinner values and you keep going up by 2 units every day till you get a pre-dinner value which is around less than 140 blood glucose as such. Now, often when the patient you have calculated, as I just showed you the example below, that we are giving 15 basal and 5 units before each meal, and the patient is not at goal, you have to give a supplemental insulin to these patients over and above the calculated values so that you can get them to better goals. And the way you calculate this correction bolus is blood glucose minus 100 divided by the correction factor. And the correction factor is calculated as 1500 by total daily dose, that's 30 units for regular insulin, and 1800 divided by the total daily dose for analog insulins. And this gives you the correction bolus. And let me illustrate this to you by example. So if, let's say, the pre-meal value is about 250 and you need to give a supplemental insulin to the patient, so the correction factor will be 1500 divided by 30, which is 50 units. So the correction bolus will be 250, that's blood glucose, minus 100, that's 150, divided by the correction factor, which is 3 units. So you will tend to give 5 plus 3, 8 units before the meal to compensate for the higher glucose values than the calculation that you had done as per their body weight. Now, you have to keep reassessing your insulin requirement on a daily basis, and you keep looking at the entire day's glycemic control, his glycemic variability, how much of fluctuations the patient has had, has the patient gone into hypoglycemia. So if you find that more or less the patient has been under a good control, you don't make changes in the previous day's total requirement and you keep following the same regime. If the patient's fasting and pre-meal was between 140 to 180 in absence of hypoglycemia, you may increase it by 10% if you find that you need to sort of bring a little better control. If the patient was totally uncontrolled, you increase by 20% the total daily dose calculation, and then you follow, of course, the calculation that I just mentioned to you. Now, at times you may have overestimated and the patient may have gone down, in which case you need to cut back the insulin by 10% or 20%, depending on what was the lowest point of glucose that the patient had in the day. So if I have to just sort of make a summary of this, more or less in the hospital environment, we tend to put the patient on insulin. Oral agents are not recommended. Oral agents are only recommended when there is going to be one missed meal in a day. For example, a patient is coming in for a cataract surgery or for a hospitalization for a single day, where we don't anticipate there's going to be any tissue damage or major fluctuations, or the patient is not very sick and the patient is very well controlled, you may continue the patient on oral agents. But more or less, most of the patients who are in the hospital would tend to require insulin. And as I just mentioned to you, that we tend to give short-acting insulin infusions in the critical care units. We give a basal bolus with either an NPH or regular or a long and short-acting insulin analogs. Premixed insulins are given at the time of discharge. And there is some role that we have now seen, that addition of DPP-4 inhibitors along with metformin in hospitalized patients, the patients tend to require lesser insulin, there's less glycemic variability, less chances of hypoglycemia, and the patients tend to do much better. Now, at the time of discharge of the patient, we need to give a regime to the patient so he may follow after discharge. So the recommendations would be that you would review the self-management with the patient, issue clear discharge summary so that you give the instructions about his insulin dosing, his oral agent dosing, how he should monitor his blood glucose, his dietary requirements. All this needs to be kind of clarified. Patients who have never been on insulin should be taught how to take insulin, and there should be clear sort of a guidance that should be given to them as to how they should sort of manage their insulin at home. Discuss the prescribed drugs, their dosages, the adverse events. All this is required that you spend time to the patient and counsel him well. Instruct on how to do the SMBGs and record keeping. And as I just mentioned to you, that his insulin needs to be discussed so that he is clear when he goes home as to how he should manage. You have to give him all the instructions as to how to recognize the hypoglycemia, and then, of course, how to treat and avoid it. Discuss the target goals that this patient requires for a good control, and stress the importance of regular follow-up with the patient. Now, if the patient was previously diagnosed diabetic and his admission A1C was less than 8%, then the pre-discharge medication should be continued at the time of discharge. If the patient's admission A1C was more than 8%, then we need to intensify treatments with oral agents and insulin. If we did not have an A1C at the time of admission, but the patient had a good glycemic control, then you reintroduce the pre-admission treatments. If the patient had a poor glycemic control, then you intensify the pre-admission treatments. Now, if the patient was previously undiagnosed and at the time of admission the A1C was between 6.5 to 7, then you tend to give lifestyle modification, metformin, follow up this patient, and then of course you can intensify treatment as the response of as to how the blood glucose responses are. If the A1C is more than 7%, you continue treatment with oral agents or insulin as per the guidelines. Now, if the patient got a stress hyperglycemia, we always have to maintain a close follow-up. If the admission A1C was less than 5.7, maintain a follow-up. If the A1C was between 5.7 to 6.4, treatment should be as per recommendation for pre-diabetes. Remember that when they did oral GTT after 3 months with patients with stress hyperglycemia, 30% of these patients tend to become over diabetics at a later point of time. So anybody who presents with stress hyperglycemia should not be left alone. There should be a follow-up program to monitor these patients on a long term, because some of these patients may actually tend to develop overt hyperglycemia and they may require treatment at a later point of time. So is treatment of diabetes in any patient a special situation? But yet there are some special situations. So I'm going to actually ask Dr. Shailaja that is my time up, or do I have to still continue? Have I finished my time?
No, you have time.
Okay. You can stop me whenever
Yes,
I've run out of time. All right. So I
no,
can.
it's going on quite well.
All right. I'm going to take another case. And this is a 50-year-old lady who's admitted to the emergency room with shortness of breath. And this is a situation that we are talking in the current scenario. She's a known asthmatic and recently has developed respiratory tract infection. Previously, a history of long-standing hypertension, has diabetes for 4 years. And as per her condition, as her condition is not improving, the treating doctor decided to start the patient on intravenous steroids along with other treatments. And the physician was primarily decided to involve a diabetologist to manage the sugars. So this is a typical scenario that we're seeing even in the current pandemic, where most of our patients who are very sick and come into the hospital and require steroids, and they suddenly find that the blood glucose goes all haywire, and we need to, step in and try and help the physicians treating the pandemic, the COVID patients, to see how best we can manage the blood glucose. Remember that when somebody develops a steroid-induced hyperglycemia, there is a suppression of the insulin secretion, there is increased gluconeogenesis, there is a decreased glucose uptake from the blunted insulin sensitivity. Prolonged use can cause beta cell dysfunction with impaired insulin release in dose-dependent manner, and glycemic effect of short-acting steroids is often exaggerated in prandial hyperglycemia, and it has less effect on fasting blood glucoses. And here you can clearly see from these graphs over here that once you give steroid to the patient, we expect that the hyperglycemia tends to occur in the second half of the day. And if you have to get the patients under a good control, then you have to counteract this glycemic surge that tends to occur in the second half of the day. The best insulin that you can give for a patient to counteract the glycemic surge is NPH. So NPH, for all patients who are developing steroid-induced hyperglycemia, the choice of insulin is to give NPH, because the NPH closely mimics the glycemic surge time that tends to occur. So the peak effect of NPH closely matches the glycemic surge of the steroid, and it can blunt the glycemic response that tends to happen. So most of us, despite whatever regime you're using in the background, you tend to add NPH only to counteract the glycemic surge of the steroid. So the patient may be on basal bolus to sort of, fulfill the requirements of glycemic control. But if you add steroid to the regime, despite whatever basal the patient may be on glargine, that's fine. You may still add an NPH insulin over and above that just to counteract the steroid-induced glycemic surge. And here's just an illustration that I've just given cartoon-wise, that if you give at 8 a.m. the steroid, by about 4 p.m. you expect the glycemic surge to happen and sort of tapers down by 12. And similarly, if you give NPH to the NPH insulin to the patient, you find that the peak effect generally occurs by about 8 to 10 hours, and that's matching the glycemic surge peak that happens with the steroid. Now, if you have twice a day steroid that needs to be given, then you will give twice a day NPH to the patient, because the evening steroid dose will tend to cause an early morning surge to happen, and the patient may develop a fasting hyperglycemia. So you need to give twice a day in these patients. The way we calculate is, of course, as per steroid potency, and you can have patients who are receiving hydrocortisone, prednisolone, methylprednisolone, dexamethasone, or betamethasone, depending, of course, on the duration of action. And you need to then calculate the steroid potency and the amount of NPH insulin that you need to give the patient. In non-diabetics, patients who are perceived to be hyperglycemia, at risk for hyperglycemia, you do the casual blood glucose, and if it is less than 200, consider the patient to be at low risk. You record the blood glucose daily post-meal. If the casual blood glucose is less than 180, consider cessation of casual blood glucose testing. If it is more than 200, then of course the frequency of testing should be increased to minimum 3 times a day. In patients who are diabetic, the casual blood glucose of more than 200, then you should do a blood glucose estimation at least 3 times a day and then decide among the insulin dosing that you need to give the patient. These are, of course, the algorithms that we do for calculation of amount of insulin that you need to give as per the glucocorticoid potency and how much of NPH insulin to be calculated. And of course, if you're giving single dose prednisolone or multiple hydrocort or methylprednisolone pulse therapy, this is how you need to sort of, give the NPH insulin to counteract the blood glucose increase that may happen with the steroids. I'm just going to sort of take one more case. I don't know if I have that time. Okay, I'm going to stop here. The
Have some
challenges.
questions. Yes, yes.
So I'm just going to give my concluding slide and then end up.
Yes, please.
All right. Sorry. Yeah. Give me just a minute.
Ali.
All right. So in conclusion, hyperglycemia is an independent risk factor for poor clinical outcome in multiple patient populations. Tight glycemic control improves mortality and morbidity and reduces the cost in critical ill patients. We do not yet know what should be the optimum glycemic goals. Hospitalization is an opportunity to assess glycemic control and intensify the outpatient therapy. Until now, this issue has never been given a priority. The barriers to good control is the gap between what we know and what we actually do. And I would like to pay my respects to Dr. Guillermo Umpiras, a close friend, who's probably done the maximum amount of work in this area in the entire world. And there's no sort of journal which does not carry his paper. I've been fortunate to have been his associate, and we have sort of worked together on a number of projects. Thank you very much for your patient listening, and I'd like to thank Dr. Shailaja for this opportunity.
Thank you, Sanjay. It was very well done, and I think we have you have covered most of the very, very important aspects which we all faced, mainly because of the COVID times. It's like everywhere, the glucose management. Thank you so much. I know it was an exhaustive talk. You can get your cup of coffee. So sorry, I can't provide you from here.
Thank you so much. Thank you very much.
Okay, so let me welcome Dr. Vrushali Naik. She is with me for discussion today. She is physician diabetologist practicing in Pune. So welcome, Dr. Vrushali.
Thank you.
So we will be having some questions. So I think before Vrushali can start getting questions from the audience, I think there is one question which has directly come to me is Dr. Shashi Kiran. I think there is some confusion. Sanjay, you mentioned about Degludec not recommended. So Dr. Shashi Kiran wants to know that there is a paper from Simeoni in Diabetes Therapy 2017 where it is shown that Degludec in hospitalized critically care patients had worked very well to reduce glycemic variability. What I want to say, dear Dr. Kiran, that it's mainly, I think, Dr. Sanjay was speaking about steroid-induced hyperglycemia when he stressed about NPH use. Sanjay, you want to have additional comment?
So remember one thing, that whenever you start using Degludec, the dose stabilization takes at least 72 hours for happening. You don't have that kind of a time for basal insulin dosing to be sort of stabilization. So if you look at the typical action profile of Degludec, there is an escalating blood glucose levels that tend to occur. And by the time the dose stabilization of Degludec happens, it is almost about 72 hours. Now you need a immediate action to be done, which will sort of bring the patient's blood glucose under a good control. And that's one of the reasons why ultra long acting insulins are not used as a insulin naive patients. I would agree to you. And in that paper, they looked at patients who are already diabetes on Degludec, who already had on background Degludec. In these patients, perhaps you can continue giving Degludec because your patients already sort of dose titration has happened, and you can go up or down on the dose. But if you have to introduce insulin to the patient, then Degludec is probably not the best choice to give.
Okay, so we can use different basal insulins, and especially when you are switching from infusion pump, usually we give in the morning when the patient is still on the pump. As we saw, even subcutaneous as well as basal, we can start in between. Yes. Me to change.
Yeah.
Okay, so Dr. Vishali, are there questions from the chat box? Yeah.
Yes. So there is one important question from Dr. Gupte. He's asking that are we using continuous glucose monitoring in ICU patient?
Are we using it, Sanjay? What are you doing?
So we are not using very much in the ICU patients. We tend to use it at times in the wards. The reason being is that you have to be careful about using it in ICU patients because if they are in shock, their tissue circulation is not very good. Remember that in CGM we are looking at interstitial fluid glucose. So if the patient is, let's say, overhydrated, edematous, or if the patient is underhydrated, you may find that there is a lot of variability that you may get. Second thing is hypoglycemia recognition becomes very late because there is a lag period between blood glucose and the interstitial fluid glucose. So if the patient has got a hypoglycemia, you may not recognize it early and the patient may stay hypoglycemic for a longer period of time. Third thing is if the patient is on inotropes, there may be a peripheral vasoconstriction that may happen and the patient's blood glucose may not be recorded in the correct manner. So patients in the ICU should not be on a continuous glucose system. There are, of course, anecdotal reports and there are trials that have been done, but you need adequate hydration. Patient should not be critically ill. Patient should not be on inotrope supports. Should not be. So all these are sort of factors that are there. But in the wards where the patient is stable, you can definitely use continuous glucose monitoring, and that tends to give you a better idea about how to insulinize the patients.
So I think when we are using continuous glucose monitoring in ICU or critically, it's mainly for the research purpose to see the trend. But for day-to-day, our management, our old systems of checking subcutaneous glucose by glucometers, I think that makes sense. So CGM is at present only for research thing, at least in Pune or in India.
Yeah. Right.
Is there a question?
Yeah. Yes. Actually, this is very well explained already by Dr. Agarwal sir, but just for their information, how do you shift patients from IV infusion to subcutaneous insulin?
Yeah, so I did mention that, and I'll just reiterate that something that you need to always remember is that you don't sort of shift the patient, you don't stop IV insulin and then you inject the subcutaneous. That's one important point amongst all the points that I want to stress to you, because this is the most common mistake that everybody does in the ICU, that they shut off the IV insulin and then inject the subcutaneous. You always have to overlap. So don't forget to do this. And then, of course, you have to follow the basic rules that you have to keep the patient should be on solid feeds before you transition the patient on from IV to subcutaneous insulin. You don't transition the patient to oral agents. You have to follow a basal bolus coverage so that you're covering the basal as well as the nutritional coverage. So these are some of the rules that you follow.
Do you stop all oral hypoglycemic agents when patients are admitted? Asked by Dr. Gandhi.
So I think touch base about that. Most of the patients who are going to be in the hospital, it depends on how long and what is the condition that they've come for. Patients who are going to have only one miss meal, then these are the patients who can and who are well controlled, then these are the patients whom you can continue on oral agents. But by and large, if the patient is going to have a longer hospital stay, if they are sick, they're going to need multiple therapies, they're going to need surgeries, then most of the times all these patients in the hospital environment should be on insulin treatment.
Yes, ma'am. There is one more question. Is anyone using sliding scale to manage glucose for indoor patients?
I know we were using a lot of sliding scales when I was doing my post-graduation and then after a few years. But then there were a lot of disadvantages of using sliding scale, and that insulin gets stacked up. There are more hypoglycemias. So you can't just look at the number of the sugar and decide the insulin dose. So every time you are taking a phone call or your sister is informing you, you need to have what is happening in last 6 hours, what has happened in last 24 hours. Unless you have that thing written or it's in your mind or it is in front of you, it is very difficult to just tell the dose by looking at the number. So sliding scale has lots of disadvantages. Still, sometimes we need to use it. And but every time it has to be known what are the previous records, what was the 24 hours requirement, and then only we can just give the dose, that sugar is so much, this is the dose. It comes from the information what has happened in last 24 hours. So I think when you are really managing indoor glucose, you need to be really involved. You can't just step in just and give some answer. So you need to know what's the patient, what is the, whether it is hypercatabolic stage, and how much is the infection, the requirement changes accordingly. So managing a glucose indoor is a lot of work by treating physician. It's not only simple phone calls. There are a lot of mathematics goes on inside the brain. So it's simple sliding scale may not be useful.
Yeah.
That time. Yeah.
Can I add a comment to it?
Yes, yes,
If I
please,
may?
Sanjay. Yeah.
All right. So sliding scales for intravenous insulin is followed. So that's what I just outlined to you. What
Yes.
is not followed is subcutaneous sliding scale.
Exactly.
But there is one caveat to it. So patients who are nil per orally, more of the times we don't give sliding scales, and Dr. Shailaja pointed out very well as to why we don't use this. There's only one scenario where we probably at times tend to use it, is patients who are nil per orally. And I did mention that we don't give glucose insulin drips to the patient anymore. The way we manage the patients who are nil per orally, let's say for a patient who's going in for surgery, is we calculate the basal insulin and give half the basal insulin in the morning, and we then titrate the subcutaneous. So we ask the patient's blood glucose to be estimated every 4 hours or 6 hours, and we calculate the correction boluses for the patient and we inject that subcutaneously. So that's the only case scenario probably where we tend to use a sliding scale by giving the patient correction boluses for better control and avoiding swings in the blood glucose. Otherwise, for subcutaneous insulin, we don't use sliding scale, as was very rightly pointed out by Dr. Shailaja.
Yes.
Yes, there is one more question to Dr. Shailaja Kale. Whether this IV insulin infusion pump should be applied for each and every ICU patient?
I think so. And I still feel it's very much underutilized. Like in lot of cardiac patients, I have seen the patients are not put on infusion pumps immediately. And even in all other critically ill patients, I personally feel it should be mandatory for each and every patient, unless the patient is extremely stable, just need a very small dose. But I will say 80% of the ICU patients who are diabetes should be managed by IV insulin infusion pump. That is good for patients. Patient may need just only basal, a small dose when requirement is less, but the infusion pumps actually titrate and make the sugar that fluctuations much less, and it can be, the time in range improves. Do you agree, Sanjay?
Yes, I entirely agree with you. I don't think there's anything better than this. Yes.
I think we have just time for 2 questions. There was one question, Sanjay, about that can we use GLP-1 analog in indoor patients when the patients are on basal bolus regimen, or maybe when the patients are on insulins in the indoor patients?
So basically the thing is we don't use GLP-1 analog in indoor patients because they cause a lot of GI side effects. And the patient who's in the hospital, who's already sick, not eating very well, anorectic, giving them a GLP-1 can be hazardous because you may cause further GI intolerance for the patient, and the patient may get into trouble. Also, some of these patients may, because the gastric emptying time tends to get prolonged with the GLP-1, so obviously the food retention in these patients may tend to happen. So somebody who's very sick may have problems in terms of retaining food, may start vomiting, and you may have a problem. So by and large, a GLP-1 is really not advocated in the hospitalized environment. But we have given patients DPP-4 inhibitors, and that just presented to you some of the things. So there is good data to show that combining DPP-4 with metformin in non-critical areas will tend to improve the glycemic control of the patient.
I think we have time only for one last questions. I think Vrushali.
Yes,
go ahead.
that can be given for both of you. What will be the role of whole teamwork, that is trained medical and paramedical staff in management of glucose?
I think, and Sanjay, it's a very important question for the team, because just a patient and the nurse who is on duty and our mobiles, this doesn't work. So what's your message to everyone to improve in-hospital glucose management? Do they need to train their sisters, housemen? What's your just last take-home message for the teamwork?
I'll break this down in my answer. One message would be to the hospital first, because hospitals have to realize that hyperglycemia is an important comorbid condition which changes the entire outcome of the patient. The hospitals have to provide background services to the doctor to see that there is adequate teams that are managing exclusively blood glucoses of the patient in the critical care or out of the critical care settings. For the doctor who's managing diabetes, it is important that he's got a good team which looks overall the perspective. You have to look at, of course, what is the blood glucose values that the patient has got, how are you going to insulinize the patient, how are you going to monitor the blood glucose. There has to be a team which is constantly following up on the blood glucose values and taking decisions about insulin dosing. Somebody who's got to be looking after the nutrition of the patient, because it is equally important that you don't miss out on nutrition of the patient. And based on the nutrition, if you're getting any changes in the blood glucose, then those compensatory doses have to be followed up in the insulin. And then, of course, teaching the patient how to insulinize, how to manage self-manage their blood glucose monitoring, how to do post-discharge management. All this comes with a teamwork. So you need a good counselor, you need a good nutrition specialist, you need a nurse practitioner who can handhold the patient. And then, of course, there is a follow-up care that is monitored very closely. The hospital has to ensure that there are teams provided so that we improve the entire experience of the patient when it comes to hyperglycemia.
Yes, thank you so much for this. And we just come to the end. I thank everyone. I thank Dr. Sanjay Agarwal. There is just last question about basal insulin. So I just put it in my concluding remarks that managing glucose in indoor patients is a topic altogether different. You need a teamwork. IV infusion pumps are extremely crucial. When the patients are in out, the all basal insulins work as an infusion pump. So that is, don't be shy of using basal insulins when patients are ready. You have to use, you can divide glargine twice a day, you can divide NPH in 2 times in a day, morning, evening, plus use subcute. You can use a degludec once a day. So please use basal just to improve the whole indoor hyperglycemia management. And as the teamwork, monitoring, everything is important. So thank you so much, Dr. Sanjay Agarwal, to be here in Diabetes Dilemma. I thank Dr. Vrushali Naik to join me for the discussion. I thank all my sponsors for the Diabetes Dilemma and for today, Novo Nordisk. I thank all my listeners and viewers today who have joined for this Diabetes Dilemma, a series of scientific events. Thank you so much.
Thank you for this opportunity. Thank you. All the best.
Bye.
Yeah, thank you so much.